welcome all our international guests, guests from Karlstad University, Sweden, guests from South Africa, our beloved students, distinguished faculty, guest speaker, and all our other friends. Today, our distinguished speaker is currently the neurologist and sleep physician at the Sanford Brain and Spine Center and clerkship director and clinical associate professor of neurology at the USD School of Medicine at Sioux Falls, South Dakota, USA. She specializes in sleep medicine and is American board certified in neurology and also in sleep medicine. After completing her undergraduate medical education at PSG Institute of Medical Sciences and Research, Coimbatore, India, with 5 distinctions and first marks in 3 subjects, she went on to do her residency in neurology from the University of Toledo Medical Center, Toledo, Ohio, where she was awarded the chief resident for the academic year 2014-15 and was peer selected GME representative of neurology from 2014-2015. She was also selected for the Neurology Resident Scholar Program in 2014. She has published 3 review articles in international journals and has 2 book chapters to her credit. She was invited as guest speaker to NeuroTalk 2019 at Osaka, Japan, where she delivered a talk on sleep issues in myopathies and muscular dystrophies. Brilliant clinician, erudite scholar, and teacher par excellence, may I invite one of my good friends, Dr. Valentina Stephen, to teach us about the medical management of Parkinson's disease. And today, we have as moderator, Assistant Professor of Neurology, Consultant Neurologist, Dr. Sujin Koshi, who has completed his undergraduate training at PSG Institute of Medical Sciences and Research, Coimbatore, and went on to do his DM Neurology in the same institution. Excellent clinician, brilliant teacher, and a great mind. Welcome, Dr. Sujin Koshi. Over to Dr. Sujin Koshi for the moderation.
Thank you, Dr. Jacob, for your kind words. At the outset, let me thank the organizers for inviting me to moderate this session. I also thank all the participants on behalf of Believers Trust Medical College for joining us today. The topic for today is clinical updates on Parkinson therapy with emphasis on medical management. After being introduced into medical literature 200 years back, shaking palsy, Parkinson's disease now constitutes the second most common progressive chronic neurodegenerative disease. After the introduction of levodopa in 1960, now we are evolving into genetically targeted therapies, monoclonal antibodies, etc. However, the treatment is still highly individualized and requires multidisciplinary approaches, including neurologists, neuropsychiatrists, physiotherapists, and ultimately the caregivers who are involved in the later stages of the disease. It's my pleasure to associate with my friend Dr. Valentina Stephen after such a long time. Over to you, Valentina. You can take out the session.
Thank you, Dr. Sujin and Dr. Jacob, for such a great introduction. And it feels so great to be even talking to you guys and seeing you today, after such a long time. And this is a great opportunity. I really thank you all for this. And I always enjoy teaching medical students. And I'm glad that today I have a chance to meet all the great students from Believers Stage Medical College. Okay, so let's start the presentation now without wasting much time. Okay, so today we are going to talk about the medical management of Parkinson's disease. I will also mention a little bit about what other things can be done in the management of Parkinson's disease apart from using the medications. Okay, I have no actual or potential financial disclosure or conflict of interest with the presented material in this presentation. Let's see what are our objectives of the presentation today. Okay, I hope each and every one of you, especially the medical students who are watching the presentation today, at least know at the end of the lecture, what is Parkinson's disease? What are the therapeutic choices available for Parkinson's disease? Medications available for Parkinson's disease and how they work. Natural history and clinical presentation of a typical Parkinson patient. Treatment of different stages of Parkinson's disease. All right. So before we watch this video, I want to give a little intro on the content of this video so it is easier to follow. So basically, Parkinson's disease is a neurodegenerative disease. So which means there is some kind of wear and tear or the breakdown in the neurons of the brain, resulting in the manifestations. So the Parkinson's mainly involves the neurons in the substantia nigra, the dopaminergic neurons in the substantia nigra. So what actually initiates this process is nothing but there is a protein called alpha-synuclein. So there is some kind of misfolding of this protein, which results in abnormal aggregation of this. As a result, it forms something called Lewy body within the neuronal structure, okay? And once this happens, as it keeps going, what happens is that the neuron gradually dies. And it not just involves one neuron, it has the ability to spread to the nearby neurons. And not just that, what happens is, the nearby glial cells, which are nothing but astrocytes, once the neuronal numbers go down, the astrocytes increase. So as a result, there is neuronal loss, and then there is gliosis, which is nothing but scarring. Okay, so there is a combination of this resulting in the manifestation of Parkinson's disease. Okay, let's watch this animation now.
Parkinson's is the second most common neurodegenerative disease after Alzheimer's. The most visible features of this disease are a slowness of movement, muscle rigidity, and tremors at rest. There are also many, often debilitating non-motor symptoms, some of which may present before the motor problems. Parkinson's affects many areas of the nervous system and different types of neurons. However, much focus has been placed on neurons in brain regions associated with the overt motor symptoms, notably a region of the midbrain called the substantia nigra pars compacta. This region forms part of a major pathway in the brain that's critical for facilitating movement. In Parkinson's, dopaminergic neurons in the substantia nigra gradually die, leading to the malfunction of this pathway and the characteristic motor problems. Drugs that replace or mimic dopamine are often used to treat these motor deficits, but they grow less effective over time. Deep brain stimulation may also be used to treat symptoms. However, no current treatment slows the neurodegeneration. A distinctive pathology in most cases of Parkinson's is clumps of misfolded proteins within neurons. Lewy bodies are the most common type. A characteristic component of these is a misfolded protein called alpha-synuclein. These molecules can form small repeated units called oligomers, or longer fibrils. Mounting evidence indicates that these are toxic to neurons and play a key role in driving Parkinson's. Unwanted proteins are normally cleared by the cell's different types of protein-degrading machinery. Some evidence points to these systems being overwhelmed by misfolded alpha-synuclein, and this might be a key factor in what kills the neurons. Parkinson's has also been linked to problems with mitochondria. Mitochondria provide cells with the energy to perform vital functions. They're highly dynamic and can fuse together or break up into smaller versions in response to a cell's energy demands. They can also be transported to areas of a cell that need them the most. However, in Parkinson's, these processes can be impaired, and mitochondria are unable to sustain proper neuronal function. As they become old or damaged, mitochondria are removed and replaced. Again, this recycling is thought to be disrupted in Parkinson's, leading to the accumulation of damaged or worn-out mitochondria. Another idea is that the cells called glia surrounding neurons may play a role in Parkinson's. As dopamine neurons are lost, one particular type of glial cell, called microglia, is thought to take up the resulting cellular debris, triggering an immune response. Once activated, they release inflammatory cytokines, which activate neighboring microglia and another type of glial cell called astrocytes. Chemicals released by activated microglia and astrocytes have been shown to injure neurons. It remains unclear which mechanisms drive the disease process in Parkinson's. What is clear is that with time, more areas of the nervous system develop pathology. And one emerging idea is that this happens through the transmission of misfolded alpha-synuclein. While the multifactorial nature of Parkinson's disease progression might make it hard to fully understand, it does provide a number of potential therapeutic targets for slowing or even halting the neurodegeneration. For example, enhancing the clearance of abnormal proteins and blocking their transmission, improving the function of mitochondria, and targeting the neuroinflammation are all currently active areas of research.
So with that introduction about what is the neuropathology of Parkinson's disease, let's now move on to see what are the therapeutic choices available for Parkinson's disease. Okay, and each one of this is very, very important. It's not enough if we just do the medications and not do the therapy, because Parkinson's disease and therapy, they go together all through the disease. Okay, so the therapy mainly includes all three types of therapy: physical therapy, speech therapy, and occupational therapy. So it should be a part of the treatment plan right from the beginning of any patient who's diagnosed with Parkinson's disease. Okay, medical management, with this the mainstay of treatment as of now. And then the surgical treatment, which is the advancement in this field and which has become a game changer in the life of Parkinson's patients. Okay, which involves the placement of deep brain stimulation. I'll tell a little bit about this deep brain stimulation in this slide because we're not going to talk about it after this. So the deep brain stimulation mainly includes, as you see in this picture, there is a neurostimulator, and then there is a lead that actually goes inside the basal ganglia. Okay, and there are different nuclei that can be targeted with this procedure. And usually for Parkinson's disease, we target the subthalamic nucleus and the GPI, which is globus pallidus interna. So remember those two nuclei. And what we actually do is we are kind of stimulating these areas with current, basically, and we are making it work better. Okay, and if once you see these patients pre and post DBS, you can easily compare how effective this treatment is, because this is a life changer for many patients. And the tremor control, the control of bradykinesia and other symptoms that we get is actually mind-blowing. Okay, so that is the deep brain stimulation. And then, as I already mentioned, therapy. So remember, there is a medical management, surgical management, and then there is therapy. So it's a team approach. So each and everything in this is very important as we manage a patient with Parkinson's disease. Okay, so let's now see what are the medications available for Parkinson's disease. All right, I don't see from where all these arrows are coming, but anyways, so this is a synapse. Okay, so I will explain this picture. So this is a presynaptic neuron, this is a postsynaptic neuron, and in between we have the synaptic cleft. Okay, so this is what happens in the brain in a normal person. Okay, so what happens? We all make dopamine in the dopaminergic neurons. Dopamine is made from tyrosine. So once the dopamine is made, it is nicely packed into these small vesicles. And these vesicles, once they are fully packed and ready to be used, they kind of move towards this presynaptic membrane. It fuses with the membrane, and then the dopamine gets released in the synaptic cleft. Okay, the synaptic the dopamine in the synaptic cleft, what will it do is basically it will go and bind to the dopaminergic receptors in the postsynaptic membrane, and it will exhibit its action. Okay, so not all the dopamine will go and bind to this receptor. Okay, some of the dopamine will be taken back by this dopamine transporter into the presynaptic neuron itself, and it will be again ready to be used for the future. Some of this will be taken by the glial cells. Okay, and in the glial cells, you have two types of enzymes. One is COMT, which is catecholamine O-methyl transferase. And then you have MAO-B, which is monoamino oxidase B. Okay, so these two will actually help in breakdown of this dopamine. Okay, once the dopamine enters into this glial cells, there is no coming out. Okay, basically they will be just degraded here. All right, so I will tell one more time just to be sure. So we have a presynaptic neuron, postsynaptic neuron, a synaptic cleft. So the dopamine is formed from tyrosine, packed into the vesicles, and then it fuses with the membrane. It gets released into the cleft, and then it can bind on the postsynaptic receptors. So it can exhibit its action. And some of the dopamine that is available in the synapse is taken back by the dopamine transporter into the presynaptic neuron, and some of it will go into the glial cells where it is broken down by the COMT and MAO-B enzymes. Okay. All right. So now let's see how the medicine work. Okay. Basically, the mechanism of action of these medications. All right. So what happens in Parkinson's disease, as we saw in the previous slide, basically they have deficiency of dopaminergic neurons. So basically they need more dopamine. So one good idea would be just give them dopamine, right? So to give them dopamine, what we use is something called levodopa, okay, which is a precursor of dopamine. So once we give levodopa, what happens to that? Basically, it will be able to cross the blood-brain barrier. You know, from the circulation, it goes through the blood-brain barrier. It goes to the same dopaminergic neurons, and it will do the same function as any other dopamine. It will be converted to dopamine, and then from then on, we know what is the story, the vesicles and how it goes into the synapse and how it exhibits its action in the postsynaptic area, etc., etc. Okay, so this is very clean and neat plan, but the problem is actually this dopamine, before it even enters the circulation, there could be a lot of things that can inhibit or prevent it from entering. Okay, so it has to really fight these enemies before it goes into the brain. So what are those? So one is peripheral decarboxylase. Okay, so we can give medication that can inhibit this peripheral decarboxylase, so we can avoid the peripheral conversion and send more dopamine to the brain. Okay, and that peripheral decarboxylase inhibitor, we have two examples. One is carbidopa and then benacerracide, but we use more carbidopa in the US than the other one. The second drug is not even available in the US. So that is one classification of drug, which is peripheral decarboxylase inhibitor. Okay, and then there is another enzyme that is also in the periphery, like what we saw in the glial cells, the COMT. It is also available in the periphery, which will also inhibit the, it will also cause the breakdown of the dopamine. So if you give COMT inhibitors, then again, it's the same idea. Basically, more dopamine will be able to enter the brain. So the COMT inhibitors, peripheral COMT inhibitors, we have examples. They are tolcapone and entacapone. Okay, so these are the medications that work in the periphery. Now let's look at the brain side. Okay, as we already saw, we know the MAO-B is present actually in the glial cells, right? So basically, if you give MAO-B inhibitors like your saligeline, rasagiline, etc., so what will happen? Again, you can prevent the breakdown of the dopamine here. So there will be less breakdown of dopamine, so that it will be available in the synaptic area, so it can be used by the postsynaptic membrane. Okay, and then you have something called dopamine agonists, which are nothing but medications that can stimulate the receptors in the postsynaptic area. So we saw in the first picture, these are the dopaminergic receptors in the postsynaptic area. So dopamine agonist medication basically stimulates these receptors and is able to work well. Okay, and then on top of this, we have the amantadine, which actually increases the availability of dopamine in the synapse. Okay, so these are the medications we have that can be used to treat the Parkinson's disease. I hope you all understand the mechanism. Okay, so precursor, which is the levodopa, and then we have a peripheral decarboxylase inhibitor, which is the carbidopa and benacerracide, and then we have the COMT inhibitors, tolcapone, entacapone. We have the MAO-B inhibitors, saligeline, rasagiline, dopamine agonists. We have ropinirole, pramipexole, bromocriptine, etc., and then dopamine amantadine, which increases the dopamine availability. All right, move on to the next slide. So this again talks about the same classification, dopamine precursor, which is levodopa. And when we talk about the different types of formulation of dopamine available. You have levodopa, which is an immediate release form. We have levodopa, which is an extended release form. And there are even preparations that are dissolvable in the mouth. Okay. And decarboxylase inhibitors, as I said, carbidopa and benzoyl. Normally, levodopa and carbidopa are combined as one single medication. And the ratio of the strength varies. Okay, we have 10-100, which means 10 milligram of carbidopa, 100 milligram of levodopa. We have 25-100, where it is 25 is carbidopa, 100 is levodopa. There is something called 50-200, 25-50, etc., etc. So there are different strengths of the combination dopamine and carbidopa, which is the levodopa and carbidopa. Okay, and then we have dopamine agonists, as I already said, bromocriptine, pergolide, pramipexole, ropinirole. And again, in the pramipexole and ropinirole, you have two types of formulations, immediate release and extended release. There is even something called rotigotine dermal patch, which the other name is Neupro patch, which is very popular here, which is a patch form, which is 24 hours. You just have to, use and change every day. And it's one of the dopamine agonists. And then there is something called apomorphine, which actually is a subcutaneous injection. Okay, usually commonly used for patients who have freezing for its immediate action. So that is another example that comes under the same category, which is dopamine agonist. And then we have COMT inhibitors, entacapone, tolcapone, dopamine releaser, which is the amantadine, and then MAOB inhibitors, selegiline, rasagiline, and again in selegiline you have something called Zydus selegiline, which is a orally dissolvable form. There is a selegiline dermal patch, and then rasagiline. Okay, so I hope so far everything is clear. I'll move on to the next one. So for medical students, so who is a typical patient for Parkinson's disease? To remember that, I would say if you remember this picture, it is easy to remember the clinical features. Okay, it's easy to start from head to toe. So let's go from the head to toe. So a patient with marked masked-like faces, basically they don't have any facial expression. They have a stooped posture. The whole body is rigid. They have this kind of posture because of the whole rigidity and bradykinesia. The bradykinesia means decreased movement. So with the decreased movement in the facial muscle is actually giving their masked faces. So because of all that, they assume this posture, which is flexed elbow and wrists. And then they have a forward tilt to their trunk. They have reduced arm swing. If you make them walk, the arms will be, held close to the body. And then there is a slightly, flexed hips and knees. And then you will have trembling or shaking of the extremities. And then once they walk, you will see the shuffling gait or short stepped gait. Okay. Things which we have not mentioned here is the rest tremor and also the bradykinesia, which is the pill rolling rest tremor is the very typical tremor you see in this patient. Okay. All right. So we just need an example. So before we move on to the treatment, so who is a typical, PD patient? So let's assume that we have a prototypical patient who starts or who is diagnosed at the age of 60 and then who dies at the age of 80, which is 20 years later. Okay. So the first 3 years, typically we call it a honeymoon period. They don't really have much of symptoms, maybe a very minimal symptoms. Sometimes they get diagnosed, sometimes they get started on treatment at the stage. And then they move on to this motor complication period, which is in the 3 to 8 year period. Okay. And that is where you will see all those symptoms. And after that, so 8 years or more of after that, you will probably start to see the resistant symptoms. No matter what you do, the medications are not really working so well. Or even if you have to increase the dose, then they actually have side effects. Okay. And then they enter into this, after 15 years of PD, they enter into this cognitive decline period where basically they start to have dementia. They are almost like completely disabled. Okay. So this is just a rough timeline, okay, of a patient. So lot of this treatment that we do depends on the duration of the disease. So it is very important anytime you see a patient with known diagnosis of Parkinson's, you have to ask when they were diagnosed with Parkinson's and when they were symptomatic with the Parkinson's. So this will give you an idea exactly where they fall in the timeline of this disease. Okay, so for more practical purposes, we will even classify it in a better way. So the first one is early stage PD, then is mild stage, moderate stage, advanced stage, and then end stage. Okay. In early stage, basically patients have mild symptoms. Okay, they have no problem doing their activities. They are totally fine. They don't even need treatment. So that is where we have the early stage. And what happens in mild stage? They start to have some symptoms that interferes with their activity. So two things you should remember. They have symptoms, and not just that, the symptoms interfere with their activities. And then they are in need of symptomatic treatment. You probably have to give them something to help these patients. And then once they enter into the moderate stage, basically they have inadequate response to non-dopa medications or low dose levodopa. Okay. And then they have inadequate response, but they don't really have much of complication. Okay, so this is like you will have a full-fledged patient with typical full-fledged diseased patient who are on the different treatment options that we can do. That is the moderate stage patients. And then we move on to the advanced disease, where you have complications from the medications, because the disease is more advanced. So if you give medications, the medications will give complications. And also the disease, has a lot of complications like motor fluctuations, like freezing, falling, postural disturbance. They have dementia, psychosis, etc., etc. That is the advanced disease. And then you have the end stage, where technically nothing can be done despite whatever option you have, and the patient is completely disabled. So early stage, mild stage, moderate, advanced, end stage. So the main criteria is how much symptoms they have, if it's affecting their activities of daily living, and what is their response to treatment. Okay. All right. So let's start with the early stage PD. Okay. So as I already said, they have very minimal symptoms. They have no threat to their daily activity. Basically, they don't even need symptomatic treatment. So why are we even talking about these people? Just leave them alone, right? But the thing is, this is a very good stage where we can try neuroprotection. So this neuroprotection is the main challenging area, or the main field of interest nowadays. Okay, we have so many medications that act on these synapses, postsynaptic area, presynaptic area, etc., etc. But nothing really stops the process of neurodegeneration, as you saw in the neuropathology video. So we need more medications that can actually stop this neurodegeneration, so we can prevent these patients from entering into advanced disease stages, right? So the most of the research now is on this early stage PD, where they are trying to start medications that can arrest the process of neurodegeneration. Okay, but so far we really don't have any one medication that is proven to be efficacious. So let's see what are the medications they have tried so far, or there are still research going on. Okay, so one is Seligelin, Rasagiline, and antioxidants. So as we know, Seligelin, Rasagiline or MAO-B inhibitors, right? So there are two studies that I want to quote. One is called a DataTop study, and the other one is blind date study. So based on this DataTop study, what they found, Seligelin actually can delay the symptomatic treatment by 9 months and reduce the risk of freezing in these patients if given for early stage PD patients. Okay, but the subsequent studies did not really prove that Seligelin was very effective. But in this study, they were able to find maybe there is some improvement with Seligelin if given for early stage PD. And then another study, blind date study, where Seligelin group required lower dose of levodopa and slower rate of worsening when compared to patients who were not treated with any medication at all in the early stage. So which is good, that is encouraging. Okay, fine, then we can give some medication to the patients in this stage, even though they are minimally symptomatic. And then Rasagiline, we have two studies that compared the efficacy of Rasagiline. One is Tempo and Adagio study. In these two studies, they found out that there is reduced rate of clinical worsening if Rasagiline was given much earlier in the PD. Okay. Then as pramipexole, they even tried adding pramipexole, but in that study, they did not see any superior benefit with the addition of pramipexole. Riluzole, I mean, I'm not sure if medical students are aware of this name. So there's a medication called Riluzole. So this is usually used in the treatment of ALS or motor neuron disease. And some say actually it impairs the glutaminergic neurotransmission by acting on the voltage gated sodium channels. And they say if it is working for ALS, maybe it might be able to help even patients with PD with their motor symptoms. But in controlled trials, they could not prove that it was efficacious. Okay, and then the next one is CoQB inhibition. As you saw in the video, mitochondria, which is the powerhouse of the cell, they are also affected in patients with PD. So if you can actually give something and help these mitochondria, that might be helpful. So CoQ inhibition might be effective. Okay, that's one line of thought. And adding dopamine agonists. There was a trial where they did, which was called CALM PD trial. But again, even in this trial, it is not clear if dopamine agonist slows progression or not. There are even studies going on where they're using calcium channel blockers and they are using statins, NSAIDs in the early stage. And, in one group, probably they saw some benefit, but they could not prove it as a long-term strategy. Okay, so the take-home message, the treatment of early stage, as of now, we really don't have any medication that works very well for these patients. A lot of research is going on, and they study medications that we actually know of that can be used in PD, and there are medications that are completely not related to PD, like a CoQ inhibition, dopamine agonist, statins, NSAIDs, etc. But so far, we really don't have anything that we can recommend to use in this category of patients. All right, so let's move on to the mild stage. Now we have some kind of functional impairment or some kind of limitation in the activities for patients in this category. Okay, so again, in this category, there are two strategies that they are used. One is levodopa sparing strategy. Okay, so if you think about it, levodopa, let's say, in the natural course of a disease of this patient, we know that the patient is going to live with Parkinson's for another 20 years, right? If we diagnose them at this stage. Okay, so you have to definitely give the best drug possible, which is levodopa, no question. But levodopa has a lot of side effects, and longer you use, there could be some increase in motor fluctuations, etc., etc. So one group of people think, let's reserve the levodopa for a later use. Anyway, we have to use it in future. But let's try to use different medications before we enter into that stage. So that is the levodopa sparing strategy, where they try to avoid levodopa as much as possible. Especially the motor fluctuations are more common in patients who are younger. So when you are in the beginning of the course of the disease, try to use other medications like our dopamine agonists, MAOB inhibitors, COMT inhibitors, etc., etc. Okay. So as I mentioned, dopa sparing strategy. And then the other group of people think, okay, why do you even have to wait to give the best drug possible? Let us give the best drug possible right away. Okay, so this best drug, only if you give in big doses, they will cause a lot of motor complications and side effects, right? So let's even use a very, very small dose of levodopa itself in the beginning. Probably these patients might be benefited from just a low dose levodopa, in opposed to giving huge doses of dopamine agonists or COMT inhibitors. Okay, that is the second line of thought. So I cannot say this is right or that is right. It depends on your comfort level, and when you're treating a patient, what strategy you want to employ. But we will talk about both the options. Okay, so dopamine agonist. Okay, if you are in the mild stage and if you want to give a levodopa sparing strategy, dopamine agonist they are supposed to be the next most powerful agent in reducing the symptoms of PD after levodopa therapy. So you can give the second best to these patients. They say if used as a monotherapy in early PD, even with sustained treatment, drug-induced dyskinesias, which is the major side effect of this levodopa medication, right? So drug-induced dyskinesia was very rare when used in when we use the dopamine agonist, okay, which is good, which is promising. But monotherapy is only successful for more than 3 years in only 30% of patients, which means by 3-year mark, dopamine agonist alone is probably not sufficient. You may have to keep adding more medications. But at least in the beginning, with just dopamine agonist, you might have good therapeutic benefit with minimal side effects. Okay, there are two major pharmacological category of dopamine agonist. You have ergots and non-ergots. The ergots, you have pergolide, bromocriptine. Non-ergots, you have the pramipexole, ropinirole, rotigotine. The side effects of ergots for medical students for the exams, okay? Long-term use, it can cause fibrosis. So fibrosis of where? Retroperitoneal area, pleuropulmonary, and pericardial area. So remember, it can cause retroperitoneal fibrosis, pleuropulmonary fibrosis, and pericardial fibrosis. And the other thing you should remember is they can have valvular heart disease. So we may have to, here we don't even use the ergots for PD patients, but if at all you happen to use, then you have to make sure you are aware of these side effects and you check their cardiac echocardiogram and etc. to look for these possible complications. And any dopamine agonist can cause pedal edema. It is 7.7% in the first year, so it is a reasonable chance to get pedal edema. So don't be surprised if you start a patient on this medication and they end up with a pedal edema. And other side effects include orthostatic hypotension, and sleep attacks. The sleep attacks, I don't know, because I practice sleep medicine, I see a lot of these patients, but I feel like sleep attacks is very, very common in clinical practice, especially patients who take levodopa, carbidopa, or even dopamine agonists. They are always sleepy. Okay, so remember this other side effect for your exams. Okay, so fibrosis, pedal edema, sleep attacks, and orthostatic hypotension. Okay, so what else can we use for this mild stage? So the next medication, as we know, is amantadine. Okay, remember the introduction picture where I showed you the presynaptic neuron, postsynaptic neuron, and the synapse. So you have to mentally imagine where this amantadine works. Okay, so amantadine actually works by augmenting the dopamine release from the storage sites and also by possibly blocking the reuptake of dopamine into the presynaptic terminal. So it increases the release of dopamine in the synaptic cleft. Okay. So why is it not very beneficial in advanced PD? We talk about amantadine mainly in the mild and moderate stage. Why is it not very commonly used in advanced PD? Okay, I'll give you a second to think about it. Basically, what happens in advanced PD, you know, the dopamine storage level, we don't even have enough storage by that time. You know, most of the neurons have degenerated, right? So there is not much there available. Then what is there to release, right? So that's why it's not very useful in patients who are in advanced PD. But in the mild stage or moderate stage, definitely amantadine has a role in treating PD symptoms. Adverse effects. So one adverse effect that you should remember about amantadine is the picture here. I'm sure medical students are already able to identify this. This is nothing but livedo reticularis. Okay, again, remember amantadine, livedo reticularis. Usual dose for treatment is 100 milligram twice daily. Okay, so the next thing we use is anticholinergic drugs. Okay, basically it helps in improving the symptoms of patients with PD. Okay, by about 20%, which is a very good percentage, I feel. It is effective for tremors, and commonly used medications are trihexyphenidyl and benztropine. Okay, remember among the anticholinergics, the ones that we use for PD are trihexyphenidyl and benztropine. In the US, we call it Artane and Cogentin. Okay, what are the side effects? So remember, if you are using anticholinergic drugs in the younger patient, no problem. But once the patient is more than 65 or 70, you have to be very careful because anticholinergics usually cause a lot of side effects in this population. Okay, sedation, as you see here, sedation, dizziness, confusion, hallucinations. You know, if you're talking about an elderly, probably the patient is already going through these problems. And on top of it, if you add this, they're going to have more problems. So we have to be very careful. And in fact, we try to avoid as much as possible in this patient population. Urinary retention, dry mouth, dry throat, constipation. Okay, if you remember from pharmacology lectures, you know, what is the mechanism of general action of cholinergic, what is the general action of anticholinergic. So you'll be able to know that the dryness is one major thing in all kind of retention. So urinary retention, constipation, etc. Tachycardia, and then in the vision, you have blurring of vision and you can have dry eyes. Okay. Again, remember the side effects of anticholinergics and remember the drugs that we use in this category for patients with PD. Okay, now let's move on to moderate stage Parkinson's disease. Okay, so the idea is, yes, now you have come to a reasonable stage where the patients are in need of treatment and they have motor complications, etc. But try not to just give whatever you have and on the highest dose possible. Okay, the rule of thumb is utilize the lowest dosage that brings about adequate symptom reversal. Okay, the least effective dose, like I always like to say, the least effective dose is always the best when you're treating a patient in this stage of disease. Okay, levodopa is combined, as we already saw why levodopa is combined with peripheral decarboxylase inhibitors like carbidopa. So you have Sinemet, and then levodopa can be combined with the other one, which is the benzoyl, which is the Medopar. As I said, we don't use it here in the US. We use only Sinemet, and in the Sinemet we have different formulations like the immediate release, sustained release, controlled release, etc. Okay, and then what is the why we are actually why we are adding this peripheral decarboxylase? We already saw that it prevents the peripheral conversion, but also it all helps in avoiding the peripheral side effects of levodopa like anorexia, nausea, vomiting, the GI side effects. So two things you should remember why we are adding peripheral decarboxylase inhibitors to the levodopa. Okay, so you decide whether you want to start with immediate release versus sustained release or the controlled release. Okay, so immediate release, if the patient takes the medication, immediately there is a peak So there's an onset and then they reach the peak sooner, and then again it falls off faster, right? That is the immediate release. That's mechanism. CR, the onset is little slower, but then they don't reach that high peak like an immediate release. The peak is also not big, okay? It's more sustained and slower release of Sinemet. So you can decide depending on the symptoms whether you want to go with IR versus CR. Typically, in a patient who's starting Sinemet, we like to start with Sinemet IR, but it's not like a big rule that we have to follow. It's the clinician's comfort, okay? And then you can even use both. At some point, we probably the patient probably needs both IR and CR for effective control of the symptoms. Choice of therapy, younger versus older patients. As I said, younger patients are more prone for levodopa-induced complications, the dyskinesias, etc. So you probably do not need a big dose. For older patients, the complication rate is much lesser, even if you use a bigger dose. So one common strategy that we can use is start with 25-100 milligram tablets, and then you can increase by 1 tablet per day, per week, until you reach a reasonable dose, which is 25-100 3 times daily, okay? And then once you reach that dose, and if you still don't see an adequate response, then you can increase the strength of the Sinemet to either 50 to 100. So again, remember medical students, the 200 is the levodopa, 50 is the carbidopa here, okay? So you can increase to 3 times daily. And then before you even think about adding different medications, you can from 25-100 3 times, you can increase to 50-100 up to 3 times. And then if you still don't have adequate relief, then we can add a dopamine agonist here. Okay. If after adding dopamine agonist, if you feel like the patient is still not getting adequate response, then we can actually increase the dosage of levodopa even more gradually. And you can even try the 25-150 milligram tablet, which means we are actually increasing the strength of levodopa in our tablet and trying to increase the percentage of levodopa per day. Okay, can we add entacapone for these patients? Typically, there is no right or wrong here, but we can add entacapone if you are starting to see motor fluctuations. Otherwise, I think we should be good with the Sinemet IR/CR and also the dopamine agonist. A patient response or lack of response to levodopa is very, very important at this stage. So what does it tell us? Okay, a lack of response at this stage tells us maybe it is not Parkinson's disease. Patient probably has some other type of Parkinsonism or Parkinsonism plus syndromes. I'm not sure if we have enough time to talk about Parkinsonism plus syndromes, but please note down and go see what is Parkinson plus syndrome, okay? There is something called MSA, which is multi-system atrophy. There is something called PSP, which is progressive supranuclear palsy. There is something called CBD, which is corticobasal degeneration, and there is something called Lewy body dementia. So these are all some examples for Parkinson plus syndromes. So usually Parkinson plus syndromes are patients who do not show adequate response to levodopa. Okay, so the response or lack of response makes us rethink our diagnosis. Are we in the right diagnosis? Okay. So what is that reasonable dose? If I give 25-100 3 times a day and patient is not getting adequate response, does it mean the patient has Parkinson plus syndrome? Not really. You really have to give a very good dose. Okay. Actually, the literature says 1000 milligram to 2000 milligram per day of levodopa. Until you approach that stage, you do not decide that a levodopa that you have given is not working. Okay. All right. So one other thing you should remember, right? As PD worsens, the duration of effectiveness of a dose of levodopa becomes shorter. So let's say I take a levodopa and it works for X amount of hours. Okay. The same dose of levodopa 3 years later probably will not work for that X amount of hour. Okay. It is going to be a little lesser. Okay. The duration of response gradually decreases as the duration of disease progresses. Okay. The effective clinical half-life of a dose of levodopa declines in relation to both worsening of symptoms and also duration of disease. As I already said, the symptoms also worsens and also the duration of disease kind of goes more and more, then the half-life of the dose actually keeps coming down. Okay, so now we are approaching the advanced stage. Okay, this is where you face a lot of these challenges. Okay, so what are these issues? Okay, so fluctuations, dyskinesias, and sensory or behavioral or autonomic issues. Okay, I really don't know how these things came. All right, so it's not my fault. Anyways, so fluctuations. So what are the fluctuations we can have? You're going to see each and everything soon, but let's see what are the fluctuations, okay? Slow wearing off, sudden or random off, super off, yo-yoing, delayed on, dose failure, variation with meals, and sudden freezing. We are going to see this soon, okay? So don't think I'm just jumping to the next one. Dyskinesias, we have peak dose dyskinesia, diphasic dyskinesia, end of the day dyskinesia, and then you have off dystonia and also myoclonus. And then apart from the motor complications in the advanced stage, you can also have sensory or behavioral or autonomic complications, which will include like pain, akathisia, depression, anxiety, drenching, sweats, and then abdominal bloating, dyspnea, sensation of urinary urgency, etc. Okay. So what is an off state? Okay, basically, suddenly the Parkinson's symptoms returns. Okay, and patients, when they are fine, they took the dose, they are happy, fine, they are doing their activity, but suddenly they strikes the symptoms back, the patient's back. So that is called an off stage. Okay, what kind of symptoms? Like bradykinesia, tremor, rigidity, immobility, sudden freezing. So all this together we call it an off state. Okay. So it is usually, even the off state is very mild initially, and as the disease progresses, it becomes very severe. Okay, and why do we have this off state? As I already said, as the disease advances, basically from long duration of response, patients go into a short duration of response, group, and that is what we experience as wearing off. Okay. All right, so let's see what are these super terminologies. Okay, super off. So off state is actually more severe than the untreated Parkinson's. Okay? They probably would have been better even without treatment, right? So it is so bad. Such a bad off state is called a super off state. Okay, and either it can happen at the end of an on state when they take the medication is working so perfectly well, that is the on stage, and suddenly at the end of the on state they go into a super off without gradually going down. They just suddenly go to the super off state. Or it can even happen immediately after you take the levodopa dose. The next thing is called yo-yoing. Okay, it's a fun name, I guess. So this means patients move from off stage to on stage with some dancing in between, which is nothing but the dyskinesia. Okay, and then again they go back to the off stage. So off, on with dyskinesia, and then again off. So that is like they go all over the place. Okay, suddenly they are on, suddenly they are off, suddenly they are dancing with dyskinesias. So that is their yo-yoing. Okay. And there is something called delayed on. Patient took the dose, but it's not kicking in. Okay, so that is, it takes more than 30 minutes for the dose to kick in. And why it happens? As we know, patients with Parkinson's, they can have delay in gastric emptying. So because there is a delay in gastric emptying, basically it takes time for the medication to start immediately. Okay, that is delayed on. And then you have a dose failure, which is nothing but levodopa fails to kick in at all. So no matter what you gave, there is no response. That is dose failure. Okay, so what is dyskinesia? So dyskinesia, which means it is an excessive on state, which means to have excessive movement. Okay, it happens usually when the dose is really high, peak concentration of the levodopa dose. Most common kind of dyskinesia is chorea. So I hope all medical students know what are the different types of abnormal movements like chorea, akathisia, balism, dystonia, etc. I'll quickly give you the definition. So chorea is nothing but it is an abnormal dancing type of movement where there is no rhythm and there is no one particular location. Suddenly it's the hand in one side and suddenly it jumps to the shoulder area and suddenly it goes to the leg area. So there is no rhythm. So it's dancing without a rhythm. Okay, remember like that. That is called your chorea. Okay, abnormal dancing movements that flows from one location to the other. That is your chorea. And then you have balism, which is nothing but flinging movements, flinging type of movements. Okay, they fling. And then dystonia, which is sustained muscle contraction. Okay, so like a spasm. So initially it's the dyskinesia in PD patients starts as a chorea, but you can even see some ballistic quality and dystonia as the disease progresses. And as I already mentioned, there is a peak dose dyskinesia which happens at the peak of the dose. Okay, and once the concentration of levodopa drops, the patients themselves get better. Okay, and usually this peak dose dyskinesia involves more of the neck and upper body. And then you have diphasic chorea and dyskinesia, which happens at the beginning and also at the end. So it's even more challenging. It happens at the beginning of the dose, and when the dose ends, you start and end with the dance. Okay, so that is your diphasic chorea and dyskinesia, and this one predominantly involves the legs. And not just the motor complications, you can even have sensory issues And that is because it involves the dopamine in other areas, not just the substantia nigra, but it also involves the dopamine in the limbic area, cortical areas, hypothalamic and peripheral. So because of all that, you have other kind of symptoms. Okay, so why these complications happen? Okay, let's see why. If the patient says, why doctor, why suddenly I have these complications? You can tell them, hey, more severe the disease is, more the severity is, basically you are at risk of having the complication. Okay, higher we go on the levodopa dosage, higher is the chance to get these complications. Older you are, you have, you are probably entering into the stage of motor complication. And longer the duration of therapy, then you are at risk of having complications. So why? What are the possible mechanisms? So as I already mentioned, the capacity where in the brain where you are storing the dopamine, that itself, the storage capacity is very small as the disease progresses. So, whatever medication you give, you have higher risk of side effects and motor complications than the actual action. Okay, so the small storage capacity. The next mechanism could be altered dopamine receptors. So the receptors with disease progression, they don't work the same way. So they are altered. And then fluctuation in the plasma levodopa concentration. So the three possible mechanisms to have motor complications in advanced disease: small dopamine storage capacity, altered receptors, and then fluctuation in the plasma level. So, okay, how are we going to treat? Okay, if there is a wearing off without dyskinesia, okay, so basically the dose effect is coming down, right? So with the levodopa, now let's add other things. Let's add an MAOB inhibitor. Let's add a COMT inhibitor. Let's add a dopamine agonist. So probably you can prevent that wearing off. Maybe the patient needs an extra kick now. Okay, so you probably add these medications. So that is one strategy. Or from IR, if the patient is already on IR, you can switch to Sinemet CR. So you are not having that sudden drop. It is probably going to be more sustained. Okay, or give frequent dosing. Okay, maybe if the previously patient only needed every 4 hours, now probably you have to increase to every 3 hours. Okay, so give frequent dosing to prevent the wearing off. Or now they even use zonisamide, which is an anti-epileptic, and even adenosine A2A antagonist. Again, these are all still under research. Can also be tried for wearing off dyskinesia, as they say. But practically, I have not used these medications in our patients. Dose failure. Okay, basically, as I said, no matter what you take the medication is not working. So what shall we do? Let's try to dissolve the levodopa in a liquid before they take the medication. So that is one idea. Okay, dissolving levodopa might help with dose failure. And then there is delayed on, as I said, more than 30 minutes for the effect to kick in. So what shall we do? Again, the same idea, like let's try to dissolve the levodopa, or you can tell the patient, hey, you know what? If you add your levodopa to a soda, like a Pepsi or Coke or whatever, the carbonated drink, actually it will help in earlier onset of action. So that is one idea you can give your patients. Okay, add a carbonated drink for delayed on. Weak response, end of the day. As the day progresses, the response is not as good. So what shall we do? Let's increase the afternoon or evening dose. Okay, if that is not possible, let's add a CR form towards the end of the day. Or let's add other medications like dopamine agonist, amantadine, or even anticholinergics if the age is okay and if they don't have side effects. Okay, so addition of these towards the end of the day might help. Response to meals, it is very important. You have to tell the patients, educate the patients when you're starting them on Sinemet that the food you take is going to interact or affect the absorption of the levodopa. So if you tell the patient, you take the medication at least an hour before or 2 hours after you eat. Okay, especially proteinaceous food, let's say thick milk, curd, those kind of things, or even high meat consumption. They can all actually interfere with the absorption. So they will say, I'm fine in the morning, but as the day goes, as I keep with meals, if I take, the effect I'm getting is not adequate. So that is because food is actually interacting with the absorption of the medication. So timing the dose between meals is one big thing you have to tell all the patients. And also non-protein meals for lunch and breakfast. Okay, especially here in the Western side, they consume a lot of protein for all 3 times, right? So basically, if it's really advanced, you can tell the patients, why don't you stop eating protein for lunch and breakfast and just compensate for the protein intake for the day during the dinner time. Okay, that is the other idea we give here in these patients. Freezing. So freezing is nothing but they just freeze. Okay, like a statue. Suddenly they stop. They will be moving, and if you see, they suddenly stop and they can't move no matter what they do, right? So that is called freezing. So there are 2 types of freezing. One is off freezing and the other one is called on freezing. When they're off, it makes sense. Okay, the medication is already off, so they freeze. So prevent the off, that's the treatment, right? So try to prevent the off, like already I mentioned, add other medications, increase the frequency, switching to Sinemet. So if you prevent the off, probably you can prevent the freezing. But there is some patients who have freezing when they are really on. So if they are having freezing when they are on, then you have to reduce the levodopa usage. So make the on phase a little milder. So reduce the levodopa dosage. I think there is too much of information here, but I will go over it one more time. So wearing off, dose failure, delayed on, weak response end of the day, response to meal, and freezing. So if there is wearing off, as I already said, add other medications, switch to CR form or increase the frequency. Dose failure or delayed on, you can dissolve it or use it with a carbonated drink. And if it's end of the day weak response, you can add the evening dose with meals. Always tell the patients how they should time their food and the medication, and how you deal with the freezing. Dyskinesias, again, peak dose dyskinesia, it happens at the peak of the dose. So prevent the peak, okay? Reduce the dosage of levodopa. Add higher dose of dopamine agonist and reduce the dose of levodopa. As I said in the previous slide, when we talk about dopamine agonists, even with higher doses, the dyskinesia rate is much lesser with the dopamine agonist when compared to levodopa. So substitute to higher dose of dopamine agonist rather than higher dose of levodopa. And the general thing, like smaller dose, more frequent doses, and adding dopamine agonist or amantadine might be helpful. So this is another thing we should know. So amantadine, as I already said, advanced stages, it's not very helpful for the PD symptoms, but for some reason, for the dyskinesia, amantadine is very, very helpful. Okay. There is even a longer acting form of amantadine. We call it Gocovri that we use now, and it is very, very effective for dyskinesia. So remember amantadine in advanced stage for peak dose dyskinesia. And then there is diphasic dyskinesia, as we see, both in the on stage and the off stage. So again, you can utilize a dopamine agonist for these patients. Off dystonia and off painful cramps. Again, prevent the off stage. Any side effect you get in the off stage, prevent the off stage as much as possible. So you can try to use a Sinemet CR, or they even say if there is really bad dystonia, give them a drug holiday for a day or two, and then again reintroduce the Sinemet. And they say this is really helpful for these patients, especially if they're going into dystonia, and if it's really painful, why do you even bother about dystonia? No, it's painful for some of these patients. So sometimes giving them a break might be helpful. Okay, so this is again another busy slide, but there is nothing much here, okay, actually. So behavioral symptoms, sleep-related symptoms, autonomic symptoms, and gastrointestinal symptoms. So behavioral symptoms, as we see, patients have dementia, give dementia medication. Donepezil, rivastigmine, galantamine. Patient have depression, there is no special strategy we use. That's just like how you manage any other patient with depression, you manage. Psychosis, same way. Anxiety, same way. Apathy, you can give them some stimulants like methylphenidate. Fatigue, give them wake promoting agents like modafinil. Okay, so keep in mind these patients are prone for non-motor symptoms like behavioral issues, sleep related issues, and etc. You should just look out for it. Don't just focus on their motor symptoms. Ask, how is the memory, how is the mood? Patients with Parkinson's, a lot of times they can be socially withdrawn. So always ask for symptoms of depression. Psychosis, it's very common to have hallucinations and stuff in these patients. So ask, and if needed, you have to get a psychiatry referral and get them evaluated by a psychiatrist, or if you're more comfortable, you could even start these medications and start the treatment. Okay. Sleep related problems, again, I see a lot of these patients with my sleep practice. So patients have daytime sleepiness, insomnia, REM behavioral disorder. Okay, for medical students, remember this REM behavior disorder where you have dream enactment. They act out in the dreams in the REM sleep. Okay, dream sleep is REM sleep anyways. So they act out in their dreams. So what happens? Basically, they have kicking, punching during sleep, and they can even potentially hurt the spouse who sleeps next to them, right? So you have to talk to them about their safety, spouse's safety, make sure there are no weapons in the room, there are no heavy objects that they can throw on the spouse, etc. So you have to talk to the patients about the bedroom safety here. Okay, treatment for that is clonazepam, or the other treatment is melatonin in the beginning, and once it is really severe, we like to go with the clonazepam. Restless legs, very common again in patients, but then the treatment for restless legs is pretty much the same as the PD, which is the dopamine agonist and Sinemet we can give. And if it's really resistant, painful restless legs, you can give tramadol or even oxycodone. Autonomic symptoms, orthostasis is very common in patients with Parkinson's, especially with longer duration of action, longer duration of disease. And treatment is fludrocortisone, midodrine, pyridostigmine, like how you would normally manage orthostasis. Urinary symptoms, oxybutynin and detrol you can try. And again, impotence, you can give sildenafil. Gastrointestinal problems like constipation, very, very common in patients with Parkinson's. So you can give them the fiber and the Rancho recipe, which includes, adding like a prune juice to their diet. And then polyethylene glycol or Miralax we call, okay, to treat the constipation. And nausea and sialorrhea, again, another issue we face in patients with, they have drooling in their mouth. So you can try some glycopyrrolate. If it's really severe, you can even try Botox injections of the salivary glands. Okay, so again, this is a general thing. This has not much to do with Parkinson's or Parkinson's medications, but expect these non-motor complications in these patients, and you can start appropriate treatment. Okay, that's all is my presentation. I think you're right on time. So let's quickly summarize. We should definitely know by this time, if you're paying attention, what is the pathophysiology of PD, what are the different treatment modalities, medical treatment, surgical treatment, and also the different types of therapy, PT, OT, and speech. Medications available and their mechanism. We should by now be very, very clear where the medications are working and what is the mechanism and what are the possible side effects and in which stage of disease what we will use. The different clinical stages, early stage, mild stage, moderate stage, advanced stage, and end stage. And then how we are going to use the treatment in each of these stages. Questions?
Thank you, Dr. Valentina. It was an amazing presentation. Over to Dr. Sujin.
Yes, it was an excellent presentation. Valentina, once again, I appreciate you preparing for this and you having time in your busy schedule. And you have excellently covered all the medications, in which stages, what medication we want to use, and it has been all clearly conveyed. And at the end, you have summarized the non-motor manifestation of Parkinsonism and its management also. So, as I told in the beginning itself, it should be highly individualized, and we have to aspects of the Parkinson in high detail. So, for the patient satisfaction, it's not just leaving only the motor symptoms, but there are n number of factors we have to take care of. If we know the exact pathophysiology and how the disease progresses, we can. I think most of the physicians can take care of all the aspects of Parkinsonism. So I have one question, Valentina, that the syndopa or carbidopa-levodopa, most of its action is dependent on the absorption. So one of the factors I learned to know is the H. pylori factor, H. pylori infection in the gut. Will it affect the absorption, or we want to eradicate it before giving it? What is your take?
That's very true. So that's again another important thing that we know now is that H. pylori actually can affect the absorption of this medication. So you have to actually treatment of H. pylori infection actually might help in better absorption of this medication. I mean, I don't think we routinely look for it in all the patients, but if somebody is having really bad issues and having some trouble and also really bad GI symptoms, then automatically we are going to start treatment for the H. pylori. But yes, it is known that that can affect the absorption of levodopa carbidopa.
So we don't usually frequently use the CR preparation of syndopa. They are more prone for dyskinesia or sort of motor fluctuation. What is your opinion regarding that? It is still beneficial, all CR preparation?
Okay, so in the US, actually, as I already said, we usually start with the IR, and CR is usually added. The idea of when you talk about a CR, you're imagining it to be like a a little later onset and a slower peak, so that it will last in the system for a long-term basis. But actually, in practical purposes, they found out that CR is also giving more dyskinesia, as Dr. Sujin mentioned. So do we really use it here? Yes, we actually commonly use it here. But we try to reduce the dosage of it. If you're so worried about the dyskinesia, we like to reduce the dosage of it. So there is some reason why you're adding a CR in a patient who's already on IR. So if you're worried about the motor fluctuations and dyskinesia, then try to go with a smaller dose or lesser frequency. You just add twice a day rather than going like 4 times. So probably Sinemet IR 4 times and then add a Sinemet CR twice a day or something. Not a huge dose. So to answer your question, we use it very commonly here.
Regarding the side effects of what you told, amantadine will cause libido reticularis, or dopamine agonist will cause edema. At this point, do you actually stop the medication or reduce the dose? What you do in your side effects? What you do?
So obviously it depends on how bothersome it is. If the pedal edema, if it is mild and patients, you encourage the patients to, lift their feet and all those, general conservative things, compression stockings, etc. But if you think it is really severe and the patients don't want to, and obviously we have a lot of choices. You don't really have to go with the dopamine agonist or amantadine for that matter. So if switching is possible, we switch. If it is mild, reduction in dose can be tried.
So one of the non-motor symptoms I am very much interested is the REM sleep disorders, as you are also working on that. When we are to subject that Parkinson patient for polysomnography, is in the initial stages, or you leave it for the later stages? Does it the early stages of REM sleep disorder indicates it's a clue for MSA? What is your
So,
take?
that's a very, very good question. I was about to say that, but because of the time issue, I just stopped. That's a great question, Dr. Sujin. So the thing is, REM behavioral disorder, which is the dream enactment, starts even like 20 years before the diagnosis of actual Parkinson's. So let's say somebody is going to have a Parkinson's disease in 60, 65. They might even have dream enactment as early as in their 40s. Okay, so it's a very early indicator of neurodegeneration. As you mentioned, the REM behavioral disorder, if it happens, that doesn't mean the patient has MSA, because any of these alpha-synucleinopathies can give rise to REM behavioral disorder. So you have not just Parkinson's disease, MSA is also an alpha-synucleinopathy. You can even have Lewy body dementia. So even any of these three actually can cause REM behavioral disorder. So just because a patient has RBD, it doesn't mean the patient is not PD. Okay, so it can be any of these three synucleinopathies. And when do you need a polysomnogram? Obviously here it is insurance driven. So even if you wish to get a sleep study for many patients, it's not possible to do it right away. But if you really think about from the patient perspective, anybody who has symptoms, let's say excessive daytime sleepiness, okay, snoring, if they have other symptoms of sleep apnea, like gasping or choking in sleep, they stop breathing in sleep, like apneas, or dream enactment to the extent if he's kicking and punching the spouse, or he's falling off the bed, or like having fractures, all these things is a big indication that you can actually do a sleep study. I don't think we do sleep study as a routine thing for all Parkinson's patients. It's not like that. It depends on an individual basis. If they have, so I always screen my patients for these symptoms. If you have any of these sleep related symptoms, especially dream enactment, I always ask. And if they have any of this, then yes, we proceed with a sleep study. If they don't have any of this, then I tell them, hey, you have this possible diagnosis of PD. So you are at risk of these sleep related complications. So we have to periodically review their history and then do a test as we go. It's more of, and as you already mentioned, it's individualized, depending on how the patient has symptoms.
Regarding the different preparation of levodopa, in your center, do you use enteral infusions or inhaled levodopa preparations?
So the inhaled levodopa, to be frank, we have not started using both these preparations. I cannot say I work in a huge center. So here we have not started using those. But I do know of some of my faculties and colleagues in other cities where they have tried that and have used that, but I don't have direct experience.
Do you assess a genetic study in all the patients to know the future therapy, or genetics is not a routine?
You are asking about genetic study, right?
Genetic about genetic targeted therapy and it's all on phase 2 trial, it seems. It's not in the market.
So definitely no, not here, not where I work. As I said, this is more insurance driven in the US. So if you're using anything which is, it's for research purpose, then, that is a big limitation. The insurance is not going to pay for it. So you need more evidence. So by the time we started some kind of treatment on a patient, you need more evidence. They should have, gone through all those different phases, and we should already prove that this is working in their trials and this is FDA approved, and then only we can start using. So all these experimental trials are all in bigger places where, as I mentioned, few trials in the early stage, they're all still experimental. We have not started using those here.
One more final question. I always find difficult to treat the apathy in Parkinson's. Is there any proven drug for apathy?
So as I mentioned, you can try the stimulants like methylphenidate. Any stimulant might be helpful to improve their apathy or flat behavior.
Clozapine, you can try?
Sorry?
Clozapine.
I'm not sure. Again, clozapine, you have a lot of these complications, right? It can cause agranulocytosis. So you have to really, it's again like a controlled substance here. Not everybody can use clozapine. You need to have a special approval to prescribe clozapine here. So not for that purpose I have used. Usually it's more of a stimulant like Adderall or methylphenidate, like Ritalin we call here. So those kind of things.
Anything, Jacob? You want to ask?
Yeah. So that was a very good discussion. I'm extremely happy. We have one question from one of our students, as in, is early Parkinsonism needing treatment? I mean, the very early stages, does it require therapy?
Okay, so as I already mentioned, we have a lot of trials that they have done on, a lot of drugs like seligelin, rasagiline, addition of COMT inhibitors, those kind of things. Even medications completely not related to Parkinson's like statins, calcium channel blockers, they have also been attempted. So when I have a patient, practically what do I do? So when I have a patient like this, I always tell them, hey, it looks like you have Parkinson's disease, but look, you don't have any major, motor impairment, you don't have any complication. So I have some data. Some studies say some of this could help with neuroprotection and might slow the progression of the disease, or it might prolong your onset of complication if I start this medication at this stage of life. But I don't really have strong evidence to prove this. So I may be right or I may be wrong. It may help or it may not help. But definitely, we are not going to go with higher doses. So I give that choice to the patient. If the patients feel, hey, even if there are few studies that say it is helpful, then probably I will try it. Or if they say, if you don't really have strong evidence, then I don't want to take any medication from now on. So let's see how things go and I'll go from there. So it's again the patient preference and the provider preference. Even if you don't choose to treat the patient, that's fine too. But you have to definitely keep an eye on them.
Yeah. So Valentina, what about drug-induced Parkinsonism?
Okay.
Drug-induced Parkinsonism, which is the drug that you prefer in your practice?
So we give like a lot of tetrabenazine and deutetrabenazine, those kind of things. The main treatment of drug-induced Parkinson's is just stop the drug which is causing that. So that is the mainstay of treatment. So obviously there are other different types of Parkinsonism. There's vascular Parkinsonism. There is something like MPTP causing Parkinsonism symptoms. There are so many other causes, like infection sometimes even can cause Parkinsonism. So obviously we didn't go into that topic today, but that's how we manage.
So thank you so much, Dr. Valentina. I'm just opening up an open house here. Like, suppose if any of the students want to talk, probably ask a question or two to Dr. Valentina, probably you can unmute yourself and ask. It's a great opportunity to talk to an international faculty. I think you should grab this opportunity. Anyone who is interested, please do come in. We'll keep 2 minutes for this. Okay, one more thing, Dr. Valentina, for all our students, just as a value-added proposition, can you just share your journey in very short, like how you made it to the American board, and what was your journey like? Just that it could be an inspiration for our students.
Okay, so I wish I could give like a big story like in our movies, so with the title song, but unfortunately I don't have any major stories like that. I definitely didn't even think about going to the US at all at any point of my life when I was in Coimbatore or even before that. I got married and I came to the US with my husband. I had no clue what is USMLE even when I came here. But all he told me was, you have to really work hard and you should get very good scores. Otherwise, you cannot get what you want. So that's the only thing my husband said. So I really took that very seriously. Like I really started preparing, day and night, and I worked hard on my exams. So that kind of helped me to get into residency sooner, because it's very, very challenging when all over the world is competing for residency spots in the US. And especially when you are on a visa, that's even more challenging. You have people who are citizens, American students, graduates here. You have people who are green card holders who do not need visa. So obviously they take priority. And it's very challenging for international graduates to get into top tier universities. But even getting in residency itself is very it's not an easy task. So I was lucky, and with God's grace, I guess, I was able to match right away when I applied. But in the programs in the US are all very, very structured. They all have strict guidelines. So any program you choose to go into, I think you should be good. And again, here we are more subspecialty focused. More and more people are doing fellowship after the residency. So I chose to do sleep because I was fascinated with the sleep disorders and how undertreated these are. So I went and did the sleep medicine fellowship. But there are a lot of options: people who do movement disorders, people who do epilepsy, people who do neuromuscular, and then interventional stroke and stroke, neurocritical care. So there are like so many subspecialties that you can do after neurology. And first of all, I didn't even know that you can straight away do neurology. Like it's almost like they pushed me into the ocean straight away. Like in India, you are like, you do 3 years of medicine and then you do 3 years of DM neurology. So by the time you finish you enter into the DM, you already have some idea about what is neurology through your general medicine. But here it is like you finish medical school and neurology is a straight residency. So you are directly pushed into the ocean where you have to see complicated stroke patients who is in status epilepticus, those kind of things. So I used to tell my husband, I don't even know if I chose the right field, because it's really difficult. Like the first year is internal medicine and then you do 3 years of neurology. So the first year was a breeze, too many people around and it was fun. Internship was very, very exciting. But then when I went into neurology, it was like calls right away, and you have to stay for 30 hours in the hospital, and you have to manage all kind of complicated strokes and status epilepticus, like all these patients. So it was a challenging journey, but again, once you finish, and it's always nice to look back and see how you started and where you are now. And now I have all of these medical students asking me how even you got interested in neurology. Honestly, I was not sure. I don't even know how I entered in this field. So my husband said, okay, fine, there is something called neurology. Why don't you want to just do a small rotation and see how you like it? And I went and did neurology, and I was like, this is what I want to do. So I just applied neurology and I got it. And I think the rest is all just
history.
So far, no regrets. I'm really enjoying, it's a very, very good field. And it's not like olden days where if you become a neurologist, what are you going to do? You're only going to give aspirin for all these stroke patients. And there is nothing much you can do. These patients are anyway going to die, right? That's not true anymore. So now we have, every disease has so many advancement in the field. DBS is a game changer for Parkinson's and other patients with severe essential tremor. The patients with MS, they are now living a normal life with all these immunotherapies and stuff like that. And I can talk like that about any field. Epilepsy, you can do VNS, you can do something called RNS, which is a neuropace device they put directly in the brain. So every field in neurology is now so advanced. There are so many treatment options. And now we know where exactly we are heading into, what field needs more research, especially in Parkinson's. As I said, we know neuroprotection is the main idea for future. So you have to focus more on neuroprotection. So all the research is now targeting the neuroprotection, how to stop this neurodegeneration. So I think everybody's on the right track now, and I'm hoping by the next 10 years, probably, like everything has some treatment, and everything is probably curable.
Eat more walnuts. Anyways, jokes apart, Valentina, you really trailblazed, and we are awed at your achievements, and your talk was extremely well received. We are grateful that you made time amidst all your busy schedule. You were sharing with me the course you are doing, your kids, and all that work that you have at office. In spite of that, you accepted our invitation and you made it, and really grateful for that. And I think our medical students also will be really thankful to you that you made it to come and teach them. And thank you so much. Dr. Sujin, thank you so much for making your time also. I know that you're a very busy person and you have really made your time, and you have come in and moderated the session quite admirably. Thank you so much. We do expect much more from all of our faculty and all of our friends in terms of more and more programs. So I think if there are no more questions, probably we can wind up the session. So thanks to all our friends who are online, all our beloved medical students, our faculty who are here, and all our delegates from abroad who have logged in, especially the people from Karlstad University in Sweden. Thank you for joining in. So that's about it. Let's meet in one more webinar. Thank you so much.
Thank you so much. Thank you for this great opportunity. I should thank you all actually. And obviously, you know, Jacob, I will not say no to you. So, you know, if you ask, obviously you get it. So, you know, that's why I agreed to do this presentation. I didn't have any big excuses to say no. So thank you so much for this great opportunity. As I say, you know, students, it's always a pleasure to teach the students. I don't know how they felt about my lecture, but I really enjoyed giving this session today.
Thank you so much.
Thank you. Thank you. Bye-bye.